Hi, my name is Keith Yeates. I'm a professor at the Department of Psychology at the University of Calgary in Alberta, Canada. Today, I'm going to be speaking to you about persisting symptoms after sport-related concussion, but first, just a few disclosures. I have grants from the Canadian Institutes of Health Research and National Institutes of Health, an editorial stipend from the American Psychological Association, book royalties from two book publishers, a couple of ongoing honoraria, and I do occasional medical legal work. So back in October 2022, I had the pleasure of being part of the expert panel for the consensus statement on concussion in sport at the meeting that was held in Amsterdam and published last year in the British Journal of Sports Medicine. As you know, the consensus process was a very rigorous one that started actually way back in 2018, thanks to the COVID pandemic, several delays, but we did eventually get to be able to meet in October 2022. The process involved a common search strategy, training of all reviewers and ratings of risk of bias, duplicate screening and data extraction, and then peer review of the manuscripts that were submitted to the British Journal of Sports Medicine. The process is summarized in the summary article that is cited here. As part of that process, I had the honor and privilege of leading the systematic review on persisting symptoms in individuals with sport-related concussion. And I want to thank all of my co-authors here and encourage you to read the full article that I'm going to summarize today. Before I begin, I just want to note that we did make a subtle but important change in terminology as we were writing the systematic review. Traditionally, we've referred to persistent post-concussive symptoms. In a very nice commentary published by Donna Broshek, Jamie Pardini, and Stan Herring, and Stan will be speaking to you after me, they advocated for a shift from the term persistent post-concussive symptoms to persisting symptoms after concussion. They advocated for this change because they suggest that the term persistent post-concussive symptoms tends to imply that the symptoms will continue unendingly, and also that they are attributable to the concussion. They suggested that a shift to the term persisting symptoms after concussions implies that the symptoms don't need to persist, but could end, and are not necessarily due to the concussion, but could reflect a variety of factors. We adopted this terminology because we think it reflects an important but subtle shift in perspective. So what do we already know leading up to our systematic review? Well, we know that up to 30% of children and adults with concussion demonstrate persisting symptoms after their concussion. We know that there are multiple pre-injury, acute, and subacute factors, both neurobiological and psychosocial, that can help to predict persisting symptoms. However, prognostic factors may not be useful for diagnosing persistent symptoms or for documenting impairments associated with those persistent symptoms weeks to months after injury. We often are presented with patients for whom we are not trying to prognosticate whether they will have persistent symptoms, but trying to understand if their persisting symptoms are linked to the concussion or to other causes. And what we need are tests and measures validated for the contemporaneous differential diagnosis of persisting symptoms. And that was the focus of our systematic review. Unfortunately, the knowledge base is surprisingly limited. From over 3,000 studies selected for screening, only 26 provided relevant data for the purposes of our systematic review. None of those studies were actually focused on diagnostic accuracy, although they often compared individuals with concussion or a history of concussion and persisting symptoms to those without any history of concussion. The focus of the studies did not meet the traditional measures or present traditional measures of diagnostic accuracy. Moreover, of the 26 studies, most were rated relatively low quality or high risk of bias, and they were quite variable in their methods, making comparisons somewhat challenging. In the graph here, we show a variety of variables that compared individuals with persisting symptoms to those without or without any injury at all on both imaging and non-imaging variables. The blue shows the number of significant differences or percentage of significant differences, and the orange shows the percentage with no significant differences. And as the graph shows, the majority of studies did not find significant differences on any of the individual measures that we examined. So where does that leave us? Essentially, the assessment of persisting symptoms and their diagnosis continues to depend primarily on ratings by the patient or their proxies. Symptom ratings should be obtained using standardized rating scales and compared to either baseline or pre-injury ratings provided by the patient, by the individual with concussion, or to population norms. It's important to compare someone's post-injury readings to their baseline or population norms, because we know that the total absence of symptoms is actually not what is the normative baseline. Most individuals will report at least a low level of symptoms, regardless of whether they had concussion. Fortunately, a variety of standardized rating scales are available for the purposes of assessing persistent symptoms, including those in the SCAT and the SCOTE, which were presented to you earlier today. What about other assessments? Persistent symptoms do show some evidence of being related to differences in brain imaging, particularly functional imaging, fluid biomarkers, obviously a lot of interest, and there's a whole section in today's meeting about biomarkers. We find some differences between individuals with persisting symptoms and those without on measures of vestibular, visual, ocular, and balance function. We also find some differences on cognitive tests, particularly complex time tests of executive function, and ratings of mood and quality of life, suggesting that post-concussive symptoms occur within a broader context. However, none of these other measures has been shown to be strongly diagnostic based on the current evidence, so that we cannot recommend any of them being used for diagnostic purposes for persisting symptoms at this time. The Amsterdam Consensus recommends a multimodal clinical assessment, ideally by a multidisciplinary team for individuals with persisting symptoms. These assessments consider the types, pattern, and severity of symptoms, and any associated conditions or other factors that may be contributing to the persisting symptoms. We recognize that the specifics of the assessment process may vary, reflecting disciplinary and professional standards in specific clinical or sporting contexts. It's important to consider a range of other diagnoses or problems in the context of persistent symptoms. Among these are mental health issues, learning or attention problems, visual, oculomotor, cervical, and vestibular problems, headache and migraine, sleep disturbance, and pain. All of these can be present before or start after concussion, and it's important to consider all of them as possible differentials. The research is limited, as I mentioned. There are very few studies, particularly in the 5 to 12-year-old age group. Results were generally not stratified by age in studies with mixed age populations, particularly those that involve both adolescents and young adults. Most of the studies were vulnerable to selection bias because many involve patients presenting to specialty clinic settings, which we know tends to be different from inception cohorts. Many relevant studies were excluded because most of the participants did not have sport-related concussions. One of the inclusion criteria for studies was that at least 50% of the participants have a sport-related concussion. We have much to learn from the study of concussions that are not sport-related. Another limitation of existing research is that most of the studies were predominantly of male athletes and from North America, limiting the generalizability of what we can learn from the existing research. Particularly important to increase the number of women and representation from broader areas around the world. In the future, research can be improved by focusing on diagnostic accuracy, by including large prospective inception cohorts, by considering the adequacy of the sample, and by examining social determinants as potential moderators. We need to begin to think about race, socioeconomic status, and other social determinants as potentially affecting the diagnostic accuracy of any test used in the assessment of persisting symptoms. We need better operational definitions of concussion and persisting symptoms. Much of the research relies on the Amsterdam Consensus definition of concussion, but that is not an operational definition. The American Congress of Rehabilitation Medicine has recently offered a more specific definition operational definition of mild traumatic brain injury that includes concussion and could be used in future research. We have no consensus definition of persisting symptoms and how to measure it in the literature. It's often measured by the number of new or worse symptoms, but we have research that demonstrates that sort of definition likely over-identifies individuals with persisting symptoms. We want to probably consider symptom clusters and patient phenotypes, because it may be that the measures that will differentiate persisting symptoms depends on what symptoms and who's showing them. We need better comparison groups, and for future research, much of the research used healthy athletes as a comparison group. A more appropriate comparison group is probably individuals with concussion who don't have persisting symptoms. And the fortunate thing is that data exists to answer this question better. And in fact, I would challenge my friends that are part of the NCAA DoD CARE Consortium to use their data to look at what differentiates their athletes who have persisting symptoms after concussion from those who don't at the time that they're assessed with persisting symptoms. That is not just the prognostic indicators, but contemporaneous measures that differentiate individuals with persisting symptoms. I'd like to thank you for your attention. I look forward to having a chance to discuss your questions during the upcoming panel. Thank you.